This video wraps up Chapter 16 of OEC 6, looking at GI, GU, and reproductive system emergencies. And in this one, we're really going to focus on the objective right here, management of a patient with a GI, GU, or reproductive emergency. A few key terms to consider here will just be references to some of the earlier particular medical emergencies that we've encountered. For management of the patient, just remember that this is mostly going to focus on supportive care because they have an abdominal problem and we're in an outdoor setting. Any type of GI, GU, or reproductive emergency will typically require an in-depth evaluation by a physician and potentially even long-term care. So what we want to do in terms of management in our setting is just really think about the patient's overall comfort. We need to determine if the problem is serious and not what the specific abdominal problem is. That is beyond what we're able to do. So our initial treatment after assessment is of course going to pay attention to any life threats such as excessive bleeds and the ABCDs. We can move the patient into a clinic or first aid room where it's warm. If we're outdoors, keep the patient warm by using blankets if you need to. Remember, during assessment, we want to both inspect and palpate, and this is done best if the patient is in a position of comfort, so they are supine, and then we can flex their knees just slightly. It may also require us from a management position to raise their head to 45 or 60 degrees, and this is going to take any pressure off of the abdominal muscles. They are in pain, and so consequently they may have some anxiety and be a little bit restless. Be empathetic. Provide supplemental oxygen as needed. If the patient is presenting with vital signs indicating shock, put them on a non-rebreather at 15 liters per minute. Check it with a pulse ox. Anticipate that the patient may vomit, so have a basin ready and be ready to clear the airway by taking off the non-rebreather mask and assisting them to the side or in the recovery position if required. Now, it may be that you move the patient from a non-rebreather to a nasal cannula. This won't be obstructing their ability to vomit if they need to. Despite their requests, nothing to eat or drink just in case their particular condition requires a surgical intervention after diagnosis by a physician. The presence of food or liquids in the stomach could actually provoke some problems, cause them to vomit, and, as we just said, potentially make surgery much more dangerous. Keep checking the patient's vital signs. They may change rapidly over time. Anticipate shock. Remember what those characteristic signs are with tachycardia and tachypnea and low blood pressure, and allow for that. Keep the patient warm and provide good oxygenation. With very few exceptions, these patients are going to have to be followed up with higher medical care, further evaluation, so we can transfer them by ambulance using ALS if it actually calls for that.